Hello, good evening, good morning, good afternoon, good day. Hello, welcome to our 2020 Global Virtual Dental Symposium Series. Good evening, good morning, everywhere in the world. Welcome to the LifeNet Health Global Virtual Dental Symposium Series. We see that there are a lot of participants are dialing in. Just a couple of minutes, some seconds. Welcome. We will present you today the second week of our Global Virtual Dental Symposium Series, Advancing Allograft Solutions. Today is the day of rich augmentation, guided rich augmentation. We have fantastic speakers on the stage, on our virtual stage today. Dr. Glaser from Vienna and Dr. Samarani from Lebanon. So just before we start, I will repeat, there are more people coming in. So now welcome, good morning, wherever you are in this world. I hope you all are healthy and safe. Welcome to our Global Virtual Dental Symposium Series. Again, today is the guided Bone Regeneration Day, week 2. We have the speaker, Dr. Glaser and Dr. Samarani, international crowd in the publicum today. But before we start, I will guide you a little bit through the house rules. So we have all of you muted, and you cannot be seen. We can see only the speakers and the presentations, but you are able to ask as many questions as you want, what you always wanted to know about guided bone regeneration. And after the presentation, I will ask all your questions, or I will try to ask all your questions to the presenters. And after the first presentation, we have several minutes for this Q&A, and then the second speaker, Dr. Samarani, will follow with his presentation. And in the end, we have again question and answering. And if we have so many questions that we can't answer them in between, we will stay a little bit longer. For all our Spanish-speaking participants, we have simultaneous translation by Dr. Ocampo from Colombia. Welcome and thank you to be here to help us with this simultaneous translation. Please go on your small globe symbol and you can choose your channel between English and Spanish. And to all of you, we have a very short survey in the end of the presentations today. Only 3 questions, and we would be pleased if you help us to go further with our seminars. So the first presenter today will be Dr. Glaser. Dr. Glaser is a head and neck surgeon actually, and holds also the doctorate degree for dentistry and oral and maxillofacial surgery. Dr. Glaser is from Vienna, and he worked there till 2013 at the University of Vienna in the department of CMF. And now in his private practice, he and his team works on a special field of pre-prosthetic jaw surgery. And Dr. Glaser has published in the last decades numerous scientific papers regarding CMF and the therapy of oral mucosal cancer. And now, Dr. Glaser, this is your stage. You can share your screen. I can hear you. You can share your screen now. Fantastic. The stage is yours.
Thank you for joining my presentation about alveolar ridge reconstruction with allogene bone by stem cell hosting. After tooth extraction and cystectomy, like in this upper jaw, often remains severe damage to the alveolar ridge, which impacts substantially on further prosthetic plans and might be such that even setting dental implants might be either difficult or even impossible. Reconstructing the alveolar ridge with bone replacement material developed tremendously in the past decades, yet still sets challenges to the material itself and to the functional and aesthetic goals. I follow a standard procedure for the reconstruction of the alveolar ridge. Every patient has a pre-diagnostic CT scan. He has an antibiotic pre-treatment before surgery, tooth extractions, cystectomies, sequestrectomies, and immediate augmentation is done in one operation. The patient's post-operative standard follow-up lasts for 4 months with clinical controls over the first 10 days until the sutures are taken out, and then performing routinely a CT scan monthly. From January 2016 to August 2020, we treated 307 patients with 430 augmentations of the jaws. Alveolar ridge plasty was performed 258 times. We used allogene cord almost exclusively. We used allogene Cortico Cancellous granules in 195 operations. We used allogene blocks 51 times and other materials 16 times, and found out that allogene bone is a very safe material for the absolute and relative augmentation of the alveolar ridge, leading to a high success rate when used with appropriate membranes. The reconstruction site is always covered by a membrane when we perform the surgery to protect the replacement material from early invasion of soft tissue and subsequent destruction. From 2016 to 2018, we used porcine pericardium membranes 161 times with a very high complication rate. Over the years, our procedure developed with developing biomaterials themselves. In the first years, we failed primarily when using porcine pericardial membranes combined with allogene blocks. Such membranes to activate the complement system, attracting polymorphonuclear cells, destroying such membranes within a short period of time, leading to soft tissue invasion into the blocks. We then changed to collagen type 1 membranes, which we used 62 times with only one minor complication. Furthermore, we used allogene cortical rib structures, which we obtained from LifeNet. We decalcified these cortical ribs for 2 days pre-operatively, using it then as a membrane, up to now 25 times with no complication. So post-operative complications were significantly associated with the use of inappropriate membranes to protect the granulous replacement material from early invading soft tissue. Now I would like to introduce you to some patients we've treated that way. This is a patient, this is the upper jaw of an about 60-year-old woman with a cyst in the lower front due to infected teeth. The lingual corticalis was highly reduced, the vestibular corticalis widely disappeared. Tooth extraction and cystectomy took place in the same session with the augmentative procedure. bone replacement material was rehydrated during the operation for about 20 minutes, after then brought into the cavity here, and then was covered with a collagen type 1 membrane, which was fixed with pins. The anatomical reconstruction was successful. Due to this CT scan done 4 months post-operatively. This is the CT scan of a 60-year-old male patient with increasing pain in the upper right jaw due to periapical cyst over the 4th and the 5th tooth. The patient needed tooth extraction, cystectomy, sequestrectomy, reconstruction of the alveolar ridge 1415 in the region 1415, and all of that took place in the same operation. After the tooth extraction and the cystectomy, the reconstruction of the alveolar ridge was done immediately. The replacement material was covered with a type 1 collagen membrane. Although the reconstruction was successful, in terms of a stable bony reconstruction, it is also visible that a slight deformation of the augmented material took place, like you see it here. Neither the granules nor the collagen type 1 membrane are resistant against pressure from all sides here. You see, we have a good reconstruction here, but here we had to deal with some pressure, so that there was some sort of deformation here. Here we gained a good result. The next CT scan shows you a periradicular cyst due to this tooth and an alveolar defect after tooth extraction in the region 2.6 done elsewhere years ago. We took out the tooth and the cyst and added a sinus floor elevation for the preparation of the augmentation procedure with allogen corticospondyous material. Also, we prepared a mucoperiosteal flap. The bone replacement material was rehydrated during the operation, and after then we filled the defect up with this allogen material. We covered it with a type 1 collagen membrane and closed the defect. Here is the result 4 months post-operatively. This patient came already edentulous in the upper jaw and an extremely poor dental status in the lower jaw, asking for having finally a non-removable prosthetics. Scan diagnostics showed large defects in the 3rd region on both sides here and here, and an alveolar defect on the right side, which was communicating with the maxillary sinus. Moreover, old dental material was found in the bone, like here. We cleaned the defect surgically with a drill and therewith had to remove a lot of bone. We combined this operation with a sinus floor elevation. Then we fitted quite large allogen blocks here and here. To restore the alveolar defects, and added Cortico Cancellous mix into the sinuses for the sinus floor elevation, for the augmentation. The blocks were fixed with screws of 12 millimeter length, and the defect was covered against the soft tissue, in that case, with fluor tetrapolyethylene membranes with satisfying results, as you see here, 4 months later. We have that, And here we restored the alveolar ridge on both sides and gained enough bone so that the patient could get his implants. Here you see again this reconstruction of the alveolar ridge. Here I show an alveolar defect in the region 1-2-1-3, which reached up to the root tip. The defect was filled with Cortico Cancellous mix, so with bone replacement material, and covered with a collagen type 1 membrane 4 months before she got her implants. And you see here some structures of the collagen membrane and the reconstruction of the alveolar ridge, and here the original bone. We had to take away a lot of bone which was infected. Here again you see the original bone and the augmentation, and here the collagen type 1 membrane. As such, restorative procedures were quite successful. We questioned about the underlying biological mechanisms, whether they are local or systemically. Studying extensively literature and matching it with own observations, we favored the systemic concept. So how does wound healing take place all over the body, and how does avital bone replacement material turn into vital bone? The concept is that tooth extraction, cystectomy, and the removal of inflammatory bone causes an injury. So this should represent the upper jaw. These should represent teeth. And here I made something like that should be the defect. Due to this injury of vessels and bony structures, messaging peptides are released into the circulation. Reaching the bone marrow, which should be here. We've done that in our own lab. That's a rib, a porcine rib, which we analyzed. Cause receptor-mediated proliferation and migration through the venous part of the stem cells of the circulation. Reach, like here, these are the stem cells which you can rinse out of such ribs. And then reaching them places all over the body, and also the damaged region of the jaw, again here. In the jaw, should be this one, through surgery, we prepare a hole, a cave, and fill it with bone replacement material. The speculation now is that the stem cells must find attachment structures here, like those they left in the bone marrow. By filling up those wounds with accidentally chosen replacement material, settling of the stem cells might also be only accidental, random. Adding such structures, like here, symbolized here, of the bone marrow, of the spongiosa of the bone marrow, to the replacement material could favor stem cell settling here, where we would like to make the reconstruction. Yeah. Reinforcing hosting of stem cells outside of the marrow, the bone marrow, where those stem cells would return if they do not find places to settle down elsewhere. We open porcine and bovine ribs and iliac crests to study the architecture of the marrow. Here you see stem cell clusters. This is the venous, quite hypoxic serum flow. This is epithelium attached to extracellular matrix structures in the rib. This is a closer look on that. This is a spongious rib part, and this is epithelium attached to it, and here you have the serum flow. We rinsed those ribs in a saline solution that looks like that, and collected it in vessels, finding that they are closely attached to each other, like you see here, covered in an extracellular matrix. And such cellular formations are attached to bone particles. The following pictures are taken out of a 20-minute film showing demineralized rib spongiosa, allogene, here, from a rib we obtained from LifeNet Health and decalcified it, given it in a saline solution and exposed it to such stem cell clusters, finding that these portions of extracellular matrix of the marrow are highly attractive to stem cells. Like you see it here, I make that now a little bit quickly. That's from films, and they attach in highly specific regions. You see here the particle we first seen of the demineralized rib covered by stem cell clusters. And these stem cell clusters are attached to the extracellular matrix here of that rib. Taking that, we added such particles here, demineralized, from allogene ribs to the bone replacement material. The remaining cortical structures of the allogene rib were then used as form-stable membranes for the reconstruction of the cortical structures of the jaw. So these are the spongious decalcified structures of the rib, which we cut in very little pieces and mix them with the Cortico Cancellous bone replacement material to fill sinus floor augmentation cavities or holes in the jaw, which we've done by cystectomy. And then we have the remaining cortical structures of the rib, which we use as membranes. So this is part of a rib decalcified 48 hours, which is then easily to cut during the operation with scissors. The spongiose is cut into little pieces during the operation and mixed with the bone replacement material. This procedure was repeated in 24 operations, and the patients were routinely followed over a 4-month period. These now are the scans of one of the patients undergoing that modified operation procedure. We saw an improvement of the cortical structure here. Of the alveolar ridge. We had a vertical and then horizontal gain of height into the oral cavity of 2 to 4 millimeters. We had no resorption until now in these 25 operations, so we did not lose height here. And what was very important for me, we minimized the risk of deformation. You see that here in the apical, in the sagittal way, we had here a good vitality, so an in-spreading vitality of the augmentative material. and here we could extend the augmentation into the oral cavity. Here you see the rib, the decalcified, so the quite decalcified rib, bone replacement material here, and this structure is decalcified cortical bone, which we obtained from LifeNet Health, which was not yet recalcified. So, as a conclusion to all of that, the use of Cortico Cancellous granules is highly successful for the alveolar ridge reconstruction. The use of appropriate membranes is crucial for the successful outcome. The use of decalcified cortical ribs is highly effective for the appropriate reconstruction of the alveolar ridge and may improve current methods. Use of decalcified rib spongiosum may contribute or even reinforce the healing and remodeling of the used bone replacement material. And the point which is very important to me is that the cortical rib structures screw strongly together with the underlying bone and minimize the risk of deformation of the bone replacement material during the healing period. Thank you for your attention.
Thank you.
Stoppen?
So, yeah. If you, yes, thank you.
Have I been too long?
No, fantastic. You are,
okay.
Thank you.
I tried to train it.
No, everything. Thank you very much, Dr. Glaser. Thank you very much, Dr. Glaser. We have already received here some questions for you. Did you try this technique in vertical defects, like in increased height or atrophied posterior mandibles?
Yes. Yes. Posterior mandibles were a very important region for that. I mean, due to I was up of telling a lot of things, and so I had to take out many pictures, yeah. And at the end, I had to choose one operation, yeah. We've made that, well, when we did not decalcify the rib, we had severe complications. The very improvement of that method was the decalcifying procedure. It is highly successful with the allogen ribs from LifeNet Health, yet it requires a little bit of biochemistry in the private practice.
Okay, and it was done with EDTA, right?
EDTA, yes. It's a pharmacy who makes that for me due to a published method.
Okay. There is a Spanish question. Dr. Ocampo, can you translate this into English? Is it possible? We can't hear you. Okay.
I can hear her. Can you not hear Peter, Dr. Ocampo?
No.
Okay. Yes. Are you in the English channel? You have to make sure.
So the question will come up. There are more questions coming here.
Peter, just give me 1 sec. I'll get you the question.
Okay.
This is
Go ahead and
Carlos.
ask another question, Peter. We can come back to this one.
Yeah. So there's another question. Have you measured the rate of resorption of this technique?
The rate of which technique now?
No.
My taking the decalcified spongiosa, mixing it with the bone replacement material and put it into the hole, into the augmentation cavity.
I see. I see.
Sorry, I can go with the Spanish
Yes.
question.
Yeah.
Please
Yep.
wait, Carlos, while Dr. Glaser answered the previous question.
Sorry, Fred.
Please wait until Dr. Glaser answered the previous question.
Oh, sorry. Okay.
Well, a resorption. If you use the rib in the upper jaw, in the molar region of the upper jaw, yeah, you have that cortical rib structure, and you do not have resorption.
Mm-hmm.
You augment the bone for 2, 3, 4, 5 millimeters. But the resorption problem is not given, because otherwise the cortical structure would disappear, and that did not happen up to now. Well, it's a limited number of operations, 25 is not so much, but it was encouraging so far that we continue this protocol.
Yeah. I have the next question, Jeff Curry. He was a little bit late in the presentation. Did you mix the allograft and xenograft for the bone augmentation?
No, never. No.
Never.
No.
Okay. What do you think was the reason to have this high failure rate, even when you used only the porcine pericardium?
A friend of mine is a biochem. He was working in the laboratories of the heart and thorax surgery in Vienna, and he undertook such scientific research about 15 years ago. And he says, when you take porcine pericardium and it gets only a slight injury, then it activates the complement system and attracts polymorphonuclear cells, which destroy them within days or within a very short time. Yes, but the method to reconstruct the alveolar ridge is that you have a stable, you have blocks, you have bone, and you need to put the membrane over that material to stabilize it. So an injury to such a membrane is very likely.
Okay, thank you. Carlos, can you now translate the question,
yes,
please?
Of course, my pleasure. Dr. Glaser, Dr. Diaz-de-Ita is asking, why is that you're using a rib if you can use the same Cortico Cancellous bone available by LifeNet?
I took it from LifeNet.
Right, but the question, Dr. Glaser, is not is why use the rib when you can use the regular Cortico Cancellous mix?
Well, the cortical cancellous mix is these are granules. They are not stable. The sense of the rib is to have a stable membrane, to have a stable form.
Right.
So that the bone replacement material is not exposed to pressure which deforms it.
Right. Makes sense.
Okay.
The rib is the stabilizing form.
Okay. Thank you. Maybe the last question, and then we go to the next speaker. What is more successful, to use the cortical part of a decalcified rib as a membrane, or the collagen type 1?
Well, successful in terms of the reconstruction of the alveolar ridge, I would say, is the rib, because you can remodel the form much better. Yeah, the collagen type 1 membrane is soft. you can, yeah, if you fix it with sutures, yeah, you get these structures into the alveolar ridge, and you cannot reconstruct these edges of the alveolar ridge. And that was one of the reasons going into this rib reconstruction.
Oh, okay. Okay. Thank you very much,
Membranes
Dr.
are fine,
Glaser, so
but
far.
the rib's better for reconstructing the shape.
Yeah. Thank you very much for this presentation. We will go now to our next speaker, Dr. Samarani from Lebanon. Dr. Samarani is a periodontist and works in the academic field as a senior lecturer and as a, of course, also as a regular clinician. And he has published in many international peer-reviewed journals and has lectured in local and international conventions on topics to the oral implantology. And his focus, some of you may know this, is on the immediate implantation, immediate loading, and the guided bone regeneration. And I think the stage is now open for you, Rawad. There he is. Welcome to our seminar. Thank you for being here. And the stage is yours. Thank you very much.
Thank you, Peter. Thank you very much. I would like to thank LifeNet Health for this opportunity. It's always a pleasure to do such kind of activity with you guys. So let's go straight. So my topic is about the allograft particulates in GBR. So as Peter mentioned, so I'm both an academician and a clinician, but mainly I'm a clinician, I'm a practitioner. So I spent most of my time in my clinic, so where I run my practice, and I go to the university one day or sometimes 1.5 days per week. That's my university in the upper pictures. So, and before starting, I would like to draw your attention about this book, this work that I've participated in. So it's a recent textbook published by Wiley. And I had the pleasure, the honor to participate in chapter 6, to write actually chapter 6 about GBR in the aesthetic area. And I invite you all to have a look at this book. So going straight into the subject, let's talk a little bit, excuse me, about ridge configuration, ridge classification, we can say. So we have obviously the vertical defect, where there is no doubt that it is a 3D defect. Talking about the lateral one, someone might argue, okay, this is a simple defect, so it's a 2 defect. But actually, if we look at it, if you want to take it, analyze this defect more thoroughly, it's also a 3D defect. So because if we look at a standard lateral defect like this one, so most of the time we need to build the bone buccally and also a little bit lingually also. And also, most of the time, there is a vertical component associated with a lateral defect. So a lateral defect is most of the time, it is a 3 defect. So our deficiency is most of the time is 3D. So what are our treatment options? What is the technique that is at hand that is able to satisfy this demand? Is it blocks? For me, of course not, because blocks are able only to augment in one direction laterally, and they are not able to satisfy my thirst for the 3D reconstruction. Moreover, blocks, even autogenous blocks, which is the mother of all techniques, they suffer a lot of remodeling, and sometimes they give great results, but sometimes also they're not predictable. And if you want them predictable, you just need to add a GBR on top. That makes no sense for me if you want to use GBR to optimize a block, so why not go straight and use a GBR technique right from the beginning? So for me, GBR is not the optimal approach. Ridge splitting, definitely not, because ridge splitting, it's typically in the lateral dimension, and most of the time we lose height with splitting, and we have so many complications. And for me, it's not a technique to adopt. So let's go for the third option that is popular, that is very much accepted and widespread internationally. It's a technique called the Curie technique. So it's a technique developed by Professor Fuad Curie from Germany. And for me, this is definitely a three-ridge augmentation technique, but I have some reserves about it. We'll talk about them. And we have the best choice, the best option to reconstruct in a three-dimensional way a deficient ridge. We have the GBR technique. That means using particulate graft and membrane. So hence my preference for particulate graft. So I've made this introduction to tell you why do I like particulate grafts and how we can shape them and model them to create the 3D shape that we wish to have. So going back to the defect that we previously described, looking at this defect that is mainly a lateral defect, but also a 3D one, we have a 2 millimeter defect, and we need to go from here to here, from 2 millimeter to 10 millimeter in width, and to be able to place an implant in the middle. How would you think we can get a result like this? Is it by using blocks? Definitely not. Splitting? No, of course not. We can only get a similar result by using GBR with predictable membranes. And also this vertical component, is it possible to get it by splitting? No, by splitting, we're going to lose. We're going to have more loss in the vertical component dimension. So what we've done in this case, we've selected a membrane, a very much predictable membrane, which is the PTFE, the cytoplast PTFE membrane. So we've stabilized it, we've perforated the cortex to have some blood perfusion, and we've placed the graft. And here comes the topic, the core of our subject today. So my preference goes for a mix between an allograft and a xenograft, and we are going to go more into the details about this graft choice. And of course, you need to handle the surgery properly, because GBR, because you have membranes, because you have the biomaterial, are very technique sensitive. So you need to execute the surgery in a very refined and perfect way. So the flaps need to be carefully advanced, and the sutures need to be very properly and tightly placed to be able to have a primary closure and to avoid complications. So this technique, the membrane technique, in non-expert hands can be more prone to problems. But if you control the technical aspect of it, this is a technique that is very predictable. So, and that's the follow-up for this case, pretty much stable bone around this implant. So talking about the Curie technique, which is the other alternative beside the GBR, that is a candidate for a 3D ridge augmentation. What about this technique? So Professor Fuad Curie, as I've mentioned, so he's German, but he's originally Lebanese, and he studied in the university where I studied, and because he being Lebanese, and he comes always back and forth to this university, to the St. Joseph University of Beirut. So I was very much impressed and still by his work. And for a while, I put myself to his technique, just for me to share with you my experience with this technique. It's a good technique. It's the best technique. It's the Curie technique, but it has its problems. So this is how it goes. So you need to go to the buccal shelf and take a piece of bone, like here, and you need to cut it in half to create those cortical plates, and you need to collect some bone shavings and fill them in between those two plates. So something like that. And after a couple of months, you need to go enter the site, take out the screws, and this is your outcome. So I've put myself for many years, for several, I cannot say many, for some years on this technique, and finally I decided to abandon this technique. Even though it was very good sometimes I had some deceptions, And most importantly, this technique is very time consuming, it's very technique sensitive, it's very morbid. You need to go and cut the patient in another site. So I know the argument that this technique is zero penny, is cost free. And for me, it doesn't make sense. It doesn't hold because you need to spend at least 1 to 2 hours of extra surgical time to collect the autogenous bone from the buccal shelf and suture it and close it. And most of the time you need sedation, you need IV sedation, you need the cost of the sedation of the anesthesiologist. So it comes at the end to be a more expensive technique and more consuming in resources. So, and sometimes I know that a lot of people now promoting this technique and advocating for it, like this group, the Real Bone Builders. I see their work on the internet, on the Facebook, and most of the time I'm not very much impressed by what they post. So it is nice, okay, you do a tunnel, you do a box, you put plates, and you build the bone. But look at the outcome. Look at the outcome. Look at the ridge width that they managed to achieve. So I don't want to do a big regeneration and ending up with only 0.5 or 1 millimeter around the implant head, because we need this bone to be stable over the years. So we need something like this. We need 8, 9, and 10 millimeter of bone width. And this is only possible with GBR. Sometimes it is possible with the Curie technique, but it's very heavy on resources. So you need a lot of bone sometimes to be able to shape a big span, a big ridge span. So you need a lot, you need more, and you're limited with the resources, with the amount of bone that you can collect. So there is always this frustration. Of course, you can cut the patient on both sides, and it becomes even more aggressive and morbid technique. So going back to the GBR, which is my preferred choice. So my choice of material is, as we've mentioned, is the mixture between allograft and xenograft. And if you want to compare my choice to what's now like more of a standard now in the GBR world. So the standard now in the GBR world is this combination, is the combination of autogenous bone and bovine bone. And this combination was proposed by many so far since the time of Boyne, when he used to use it to reconstruct the full arch maxillas, and Wang and Simeon, where they use it in layers, Boozer, Urban, and Meloni, so many. And there's a consensus that this is the best technique, the best choice. Why this is the best choice? Because autogenous bone obviously has the supposedly the osteoinductive potential and the good osteoconductive potential, and a lot of other things that we don't really know, that we have yet to discover. And the anorganic bovine bone provides the scaffold and gives the property of being a material that is resistant to remodeling, to osteoclastic activity, so it stabilizes the bone volume. So I like this combination a lot, and I used it for so many years, and I still use it. But my preference is not this combination. My preference is to take out the autogenous bone and substitute it with an allograft, because after using allograft, and especially this type of allograft, I'm going to talk about it, for 10 years, I have full confidence in this combination. I know this is anecdotal at the moment because we don't have much literature to support this claim. So you can consider it anecdotal. Of course, it's anecdotal. You can consider it, so you can take it as it is, as someone sharing his experience. So it's not a scientific fact, the equivalence between those two choices. But at least for me, I have a solid belief that this works perfectly well. Why the allograft? Because what type of allograft? So the allograft that I like to choose is a mixture between FDBA and DFDBA. So I take the best of both worlds, because we know each type of allograft has its properties, its advantages. So the FDBA has a good osteoconductive potential. The DFDBA has the collagen, has other proteins, and supposedly has the inductive BMP2. So we have a mixture of nice things together. And this combination is usually packaged like this, so 70-30 of FDBA, the FDBA mix. So the experience with this type of mixture, the 70-30 the 70-30 FDBA, the FDBA mix, goes back for 10 years now. And I started with the Anchor from Osteogenics. I used it for some time. And now for a couple of years, I'm relying on LifeNet Health and practically the same product that is called Graft MD, also 70-30. So my story with this allograft started in 2010 precisely because I was ignorant, I would say, in the allograft world, because usually I was relying on autogenous bone and xenografts. In 2010, I decided to adopt, to test at least this product. So here's what I got in a sinus in 2010. I've used this combination, FDBA and FDBA. And to my surprise, at 7 months, I had a complete recorticalization of the window. And this is something, it was strange. This was something that never happened to me with a xenograft. It used to happen with the autogenous bone, with the autogenous bone, because if you go to 2000 some years back, I used to use autogenous bone particulate in the sinus. So I take the sinus from the symphysis or the ramus, are particulated, I graft the sinus, and after some month, I have this recorticalization of the sinus. And this is something exclusive to the autogenous bone. I found it with the allograft, with this allograft. And unlike bovine bone, look at the bovine bone. Bovine bone, okay, you have the implants there, they are successful. We have a lot of papers, but we always have this granular appearance. And if you put the probe in the lateral window, so always we have the probe that goes in deep for some millimeters, sometimes 7, 8, 9 millimeters. It doesn't mean that the implants are not going to be successful, but at least there is something to point out that the healing is different with allograft. There is a better potential with allografts. This is just to point out this difference in the clinical setting about the performance of those two materials. So I liked it in the sinus, in the socket, in the ridge also. I had very nice results in the ridge at the beginning. I used it alone, not mixed with anything else, this allograft, to the point where I started to see some resorption with this allograft only in big augmentation. So like in this case, so it's a thin posterior ridges on both sides, and we have vertical component of 5 to 7 millimeter. So it's a pretty big defect to reconstruct. So I've used this allograft, and I was able to reconstruct the ridge as I would love to. And coming at the abutment connection after 5 months, 4 months, to my surprise, I had this resorption. So I've put this case because this is one of the most extreme cases. In some other cases, I didn't have that much of a resorption. Sometimes I have almost zero resorption, but just to illustrate in a very vivid way, the possibility of having resorption after reconstructing, especially in the vertical and the lateral and the 3D dimension, so going far beyond the recipient side, the possibility of having remodeling, because the allografts are susceptible to the remodeling, resorption process, turnover process. While as xenograft, they are more stingy, they are more resistant, they are more stubborn. So, and anyway, back in 2001, Simeon in his paper, he hinted to this possibility. It was just a hint in his paper because I went through these papers, each one of them. So he hinted to the resorption, possibility of resorption with the FDBA back then. So that's why my choice is to use this allograft, because it's a very performant graft. It has a lot of potential. This mix between FDBA and FDBA works out well all the time, except there is sometimes, and in challenging situations, we have a risk of remodeling. So that's why it's good to combine with it the bovine bone, going to the same philosophy of the previous graft that was proposed, the auto xeno. So let's go to clinical application. This is a dehiscence type defect. This is a dehiscence type defect. So these are short implants, and we need to make sure that we have enough thickness on the lingual part. And whatever we have dehiscence on the buccal, we need to regenerate them, especially that the implant is too short and we cannot do any compromise. So in this case, we put the membrane. So my preference for the membrane is the cross-linked membrane. This is type 1 bovine, type 1 collagen, as mentioned by Dr. Glaser. So this is something that I like so much. I don't like the pericardium so much. I don't like the native so much. I prefer the cross-linked membrane. So I stabilize it apically first to create like a pouch, and I pack the graft inside. I stabilize everything with pins. These are very solid pins, and suture, and this is the outcome. Look at the outcome. Look at this close-up view of the ridge, how everything is nicely reconstructed. We cannot see the implants. They are totally buried under the newly formed bone. And at a close-up view, we can see the bovine bone particles, how they are encrusted, embedded in the newly formed bone. And we cannot see the traces of the allograft anymore because everything has consolidated into stable bone. So this is nice to see. And if we look at this video, we had to cut the bone. Excuse me, let me lower the volume. We had to cut the bone with the burr to be able to reach to the implant heads. So we were able even to reconstruct the peak of bone in between those two implants. So very much predictable approach. And this is a close-up view. You can see even more how the bovine bone particles are encrusted in the newly formed bone that was regenerated, mediating this nice allograft. So going to another case, so this was a small dehiscence. I'm going to go crescendo in the severity of the cases. So we started with a small dehiscence. Now we are going to a more of a circumferential defect around this one. Pretty much the same surgery every time. We need to stabilize buccally first, and I like to call it like the reverse sausage technique. It's because you know Istvan Urban developed the sausage technique, which is something that is very good, very nice. It had an influence over me. So everything I do is influenced by the sausage technique performed by Istvan Urban. But the things that I like to change, I prefer to use a cross-linked membrane instead of the native. I prefer to use the allograft instead of the autogenous bone. And I like to technically stabilize buccally first. So these are the three differences with the Istvan sausage technique. That's why I like to coin my approach. I like to call it a reverse sausage technique, because I start in reverse. I start buccally first, creating this pouch. I reversed also the use of the membrane. I reversed also the use of the autogenous bone, replacing it with the allograft. So this is the reverse sausage. So you need to stretch it, as Istvan stresses the fact. It needs to be very much stabilized and secured with pins, master pins. These are the pins also developed by Urban. So very nice pins, very efficient pins, especially in the mandible. And as you can see, all the graft that was put underneath this membrane was totally transformed into solid bone. So this is before and this is after, and you can see the stability over the years, pretty much stable. And going to this defect, the anterior is a different story, because anteriors, if you want to use collagen, sometimes you can suffer a collapse in the coronal third. That's why anterior, the membrane of choice should be a titanium reinforced membrane, because you don't need to only cover the threads of the implant that are exposed. You also need to recreate in a three-dimensional way the ridge shape. So this is done predictably using a PTFE polytetrafluoroethylene membrane. So if you want to use collagen and be predictable, you need to supplement your sausage or your reverse sausage technique with tenting screws to shield the forces that are going to flatten the ridge on top. So that's why I put the implant, I put 2 tent screws on left and right to shield this graft space. So this is the sausage or the reverse sausage put in place, and exclusively biomaterials, no autogenous bone, allograft and xenograft. This is quick and easy and straight to the point and very predictable. So, and we can see the outcome. The threads of the implant is totally covered. And as you can see, we have a little bit of a collapse in the middle because we don't have a 10 screw in the middle. Sometimes I put only one 10 screw in the middle and I don't have this collapse right in the middle. And as you can see, we had to take the burr and cut the bone to reach the implant head. And remember, this is no autogenous bone being used here, only biomaterial. And you can see the quality of the bone, very stable, very consolidated, and very bleedy, a sign of vitality. And this is before and after. As you can see, we had to supplement the site with a connective tissue to have a better emergence profile. Let's look at some other cases where we don't have to put simultaneously the implants and the graft, so bigger defects. Let's look at this defect. So high lip line, we had the loss of those two teeth, two incisors, and we have a serious defect with a high lip line patient, which is something very difficult, very challenging. So in those cases, you shouldn't mess with your choice. You need to go for a PTFE, polytetrafluoroethylene membrane, titanium reinforced, to optimize your ridge volume. As for the graft choice, it's going to be the same, always the same for me. Allograft to have this nice potential in the graft and supplemented with some xenograft to give it stability. So we have a 5 millimeter of vertical component. So this is the mix, the allograft around 60%. So the bigger is the defect, the more I increase the amount of allograft. This is only empirical. So because we have no information on that. So the titanium reinforced membrane in place, the flap advanced and closed. And this is after 9 months. You can see the nice ridge contour that was created and nicely formed to be able to have a beautiful emergence profile and not have a collapse. And look at this side view, look at this angle, this 90-degree angle, reconstructing the buccal aspect of the ridge. And you can see the quality, so it's a nice quality. Remember, it's a 5 millimeter of vertical, so it's a nice, excuse me. Okay, so look at those, the implants placed. And the most important, so the implants were left submerged for around 2 months or so, 3 months. And after 2.5 months, we came back to do the abutment connection. And to the surprise, not surprising anymore for me, because it's every time, it's very consistent. Every time I come to do the abutment connection, I see that this newly grafted bone is growing even more and is covering even more the implants. So this is a proof. We don't need a histology. This is only the clinical reality speaks for itself, because the bone is continuing to grow, and it's covering the implant heads. So this is a proof that what we have here is not a magma of particles and granulation tissue. It's a living bone, because it is covering the implant heads. So as also in the previous case, I supplemented the case with the connective tissue because it's a critical aesthetic area. You can see how we are managing the soft tissue. This is before and this is after. Of course, we need to go through temporaries to carve this tissue. This is a very difficult step, sometimes even more difficult than the surgery itself. You need to be patient and to guide those tissues to remodel and to have this scalloping that we have in the natural dentition. And we can see this is an occlusal view. We have no collapse whatsoever in the ridge. The ridge is always very stable. The bone is stable. And we have also the soft tissue. And look at this with the papilla. This is something very challenging, very difficult to achieve. And these are the final crowns. We had customized zirconia abutments and crowns. And you can see it is very satisfactory for the patient and also for me. And this is after 6 years, very much stable bone volume and ridge contour. And this is before and this is after. So I'm gonna show you also another case. It's a critical, it's a difficult case. So this case shouldn't be done with the collagen. So this case is a candidate for a PTFE because we need to build the bone buccally and palatally. So always when you have those two sides that needs to be built, you shouldn't go for collagen, you should go for something very form stable, that is the PTFE with titanium reinforcement. But just to tell you the power of this technique, the sausage, so we had also simultaneous sinus that needs to be done. So we lifted the sinus, you put 2 10 screws. So when it is challenging, and still, yet you need to do, and still you need to use the collagen, you need to supplement it. You need to use a booster, which is the 10 screws to give it more stability. So we put 10 screws on the buccal and on the lingual, which is something very unusual, but still to show you that it is possible to do something predictable with the collagen. So grafting the sinus and the ridge, we've used 2 membranes. This is type 1 collagen membrane cross-link, and this is the outcome. So we were able to go from a 2 millimeter ridge to an 8, 9 millimeter ridge built simultaneously on the buccal and on the lingual using collagen, and more importantly, not using any autogenous, only biomaterial. And the main driver here is the allograft, is the 70-30 mix. And you can see the vitality of the graft, and this is the implants being in place. So I'm gonna go into this case because I've did some histologies. I have like a series of histological reports, and they are going to be part of a paper that's going to come up. So this is a 7 millimeter vertical defect. So same technique. Of course, we need to use the PTFE membrane with titanium reinforced to have a nice solid structure. And underneath, the graft is always the same. This is the constant in the equation. Sometimes we play with the membranes. We put tenting screws. Sometimes we take out the tenting screws. We don't use them. But the constant is the graft, is this allograft. There is a 70-30 mix of FDVA and DFDVA supplemented with some bovine bone to give it stability and to give it to shield it from resorption. So look at 9 months. After 9 months, in a 7 millimeter vertical augmentation, 7 millimeter, it's not 1, it's not 2. And if we want to recall Simeon 20 years ago, he used to say that after 4 millimeter in the vertical dimension, you definitely need to use autogenous bone. So now here we've broke the limit. We went to 7 millimeter with no autogenous bone, and yet very nicely formed ridge with this combination. And look at this core biopsy. When you take a core biopsy and you are able to take the piece of bone from the trifine intact, like compact, still attached together, this is already a proof before going to the histological lab that we have a nice bone formation here. Because otherwise it's going to be all unstable, it's going to disassemble. Sometimes even if you have 10 and 15% of new bone formation, this new bone, when you take it out from the trifine, is going to be to disassemble and be detached. So at the histological report, we had the nice amount of bone formation in this vertical augmentation without the use of any autogenous bone, and we went beyond what used to be. It's an empirical limit, but set and defined by Simeon. This is one of the godfathers of vertical GBR. So so just to tell you that there is potential to go a little far with this combination. So let's see also another case and examine the marginal bone stability, because in the vertical reconstruction, if you have a loss of the bone volume, it's going to show on the X-ray immediately, because we don't have any lingual plate to mask the evidence on the X-ray. So in this case, we had a couple of millimeters above the nerve, and we needed to build the bone vertically 6 millimeters. So this is an occlusal view of the ridge, and this is the typical choice of graft. So allograft plus xenograft. And as you can see, everything is very well stable. I use a lot of pins to have stability and not to have any motion. In grafting, stability is key. So, and also the surgery, the flaps needs to be managed in a very delicate way, and the closure needs to be also very precise. And this is the outcome. After 9 months, we were able to build ridge. But if you look at this ridge, so we're building 6 millimeter vertically without any autogenous bone. So, and supposedly we crossed the limit of going vertically without using any autogenous bone. So if you look at this ridge in a closer view, you can see some particles on the surface. It is true, but we're stretched the limit as far. We raised the bar, so it is normal. Unlike the first case that I've showed you, after some months we had like a solid bone. We had bone like the solid, like the cranium. But here, because we've stretched the limit so far, we're 6-7 millimeter away from the donor site. Of course, the maturity of the bone is not going to be the same on the surface. But this is not going to be a problem, because this bone, you are going to see some of it, some particles on the surface are going to be remodeled and taken away. And the rest is going to consolidate and become very stable. And this is something not exclusive to this choice of graft. Even with the more conventional choice, that is the autogenous bone and xenograft, I exactly have the same thing, because I've been using those two combinations for 10 years. And I can comfortably tell you that this something happens exactly the same with the autogenous bone combined with xenograft. And I've never seen, and I tell you again, this is only anecdotal, coming from my experience. It's not a randomized clinical trial, but I've never seen, never in any case, a superiority for using for the autogenous bone xenograft choice selection. So we look at it, you see the bone is a little mobile even. You see, some part of this bone is even mobile. It's consolidated, it's stable, it's not detached, it's attached, everything is attached together, but we placed the implants anyhow, and we've submerged, of course, everything to let everything mature, because now we had the membrane before, we've removed the membrane, and we let this newly formed graft interact with the periosteum and get the needed maturity. And this is after 5 months, so you need to give it some time to mature. And you can see this is the place where everything was mobile and everything was not very, very rigid and consolidated. After 5 months, everything is hard like rock now, and we don't have any granules. If you compare those two pictures, you can see between in the yellow frame, we have at implant placement, and here in the middle, we have after 4 or 5 months, the consolidation of the graft. So we've placed the implants, attached the abutments, and this is the follow-up of the case after 4 years, and you can see the stability. So had we had no bone in this newly grafted site, is not going to remain the same. So those particles are going to be detached gradually, and we are going to have an infection developing around those implants. But the very fact that we're seeing bone stability after 4 years means that now we have a vital bone around those implants, using only allograft and supplemented with some bovine bone, and not using any autogenous bone. So I'm going to finish with this case. So I'm going, I don't know if I exceeded the time. I can stop. I can go very quickly over this case, because extremely atrophic maxilla is a chapter on its own. And GBR, when it started decades ago, it started to treat localized dehiscence type defect or localized ridge deficiency. Now, with the experience and with time, GBR is able to treat an extremely atrophic maxilla, because usually extremely atrophic maxilla are treated in a very different way. So either you need to do a Lefort 1 osteotomy, down fracture, and put some hip graft or calvario graft in between, or do pterygoid implants. So very much invasive procedure, especially if you cannot manage the case by doing two sinus grafting, because sometimes the sinus The base of the sinus is too narrow also to accommodate implant in width. Even if you graft the sinus in height, it is not possible. And sometimes the sinus are too far apart, are too posterior, so you cannot do without reconstructing the ridge. So this case is one of them, and a typical extremely atrophic maxilla, and we are going to see how it is possible to approach those cases without the need of any autogenous bone, no hip, no calvaria, no rib, no ramus, only allograft and some bovine bone. So you can see how thin is the ridge. We have a little pyramid of bone at the level of the canine pillars. So what I use, my protocol, is to use two pterygoid implants. So I go beyond the maxilla and I anchor the pterygoid bone going from the sphenoid bone. So this is an anchor, and I use it, and I use one or two implants in the anterior area, sometimes in the nasopalatal canal, sometimes in the canine pillars, to do a temporization, a fixed bridge. And underneath this fixed bridge, I do a sinus graft and ridge augmentation at the same time. So this is the case. You see the maxilla, you see bone, but there is no bone. This is only an eggshell, only a thin layer of bone, and underneath it is hollow. So the blue dots is the location of the temporary implants. So I use regular implants that I retrieve afterwards, even if some threads are exposed, just to stabilize a fixed bridge. So I do sinus and ridge at the same time. So you can see the implants are being placed, and the sinuses were open. We had a tear in the sinus membrane that we had to deal with by patching it with a collagen membrane. So we graft the sinus, we graft the ridge in the same manner, the reverse sausage technique. So this is the ridges stabilized and covered with this type 1 cross-linked collagen membrane. And this is the temporization. So we ended up stabilizing the temporary on those 3 implants. So we have a little bit of bone where we anchored those implants. So of course we are going to have some resorption around them because the bone is too thin, but we don't care because we are going to retrieve them. And here we were not able to anchor the pterygoid bone. So we limited ourselves to those 3, but it was enough. So the patient disappeared for 14 months, not intentionally because she was traveling back and forth. So after 14 months, we removed the bridge. And this is the scan, the CT scan. So the sinus very much filled up to a height of 13, 15 millimeter. And you can see the ridge. This is the original ridge here, lower left, lower right, you can see. And the white thing is the newly grafted area. You can see the ridge width, how much we gain in width and how much we gain in height. And now we are able to place 6 implants, so 3 and 3. So the most anterior implants that you see here on the photo are the temporary ones that we need to remove. So look at the quality of the bone. So I put the probe and I exert some pressure to see if the probe is able to penetrate and go into the granulation tissue. And it was not possible. It was only possible to penetrate it for 1 or 1.5 millimeter. So this is a sign of very nice stability, consolidation of the bone. And we had to have some soft tissue procedure to repair the keratinized tissue. We're not gonna go into that. And this is the case. And this is the case also. And this is the final prosthesis. And this is the final prosthesis. And this is the control of the case. So the case is functioning very well for 6 years. We have a series of cases of extremely atrophic maxilla reconstructed in the same way, not using a gram of autogenous bone, only allograft with some bovine bone. And at the end, I need to thank you. These are my contacts, my website, and my email. I have 2 Instagram channels. One dedicated for ridge augmentation. It's called the Ridge 3D Academy. And I invite you all to follow me on this page. I have another one dedicated for immediate loading in full arch. And these are my Facebook contacts. I invite you to follow me on the second one, Rawad Samarani Implantology. And at the end, I need to say that, and that in my clinic, I have a small, like a training center where I run courses on ridge augmentation, on full arch immediate loading, and on implant placement in the sockets and in the anterior area. So 3 types of courses that I provide. And for those of you who are close to Lebanon, so it's my pleasure to welcome you. So the course runs on 2.5 days. It has theory, hands-on, and 2 live surgery, and you have recordings of the course. So it's a very well worked out course, and I invite you, if you're interested, to attend. Thank you very much.
Thank you very much, Rawad. It was a very interesting, exciting presentation. Thank you very much. I already have a lot of questions here. So, did you use titanium mesh on the top of the allograft for vertical augmentation?
I don't use titanium mesh because the titanium mesh is good in giving structure, rigidity, but it's not a membrane. It's going to allow the infiltration of soft tissues, and part of the graft is going to be invaded by the soft tissue, and you're not going to have an optimized 3D ridge formation. So
Okay.
Titanium mesh are only, the modern use, I would say, of titanium mesh is only with BMP2, with recombinant human BMP2, to allow the interaction between the BMP2 and the periosteum, because it was proved that it needs this interaction, and you cannot block this interaction by using a membrane. But otherwise, if you don't want to use BMP2, I think using titanium mesh is archaic.
Yeah. Do you do, there's another question, do you do any corticotomies prior to the placement of the bone graft?
Yes, always.
Always, right? We saw this in the end. So do you use PRF technique in your work, and what is your opinion?
I don't use PRF. I've tested it. So in 2007, I remember Joseph Shukroun came to Beirut. We met with him, and I was introduced to his technique. So I got the machine. I've tested it for a while. I was not impressed. So maybe it has some effect on the soft tissue healing. But if you do your surgery correctly, you don't need this extra boost to the soft tissue. Unless you're working in a compromised patient, in a heavy smoker, in a diabetic patient, which is already a patient that you need to refuse.
Mm-hmm. Coming back to the titanium mesh, which you are not using, would you cover then with the collagen membrane?
Yes, if you want to use titanium mesh, of course, definitely you need to cover it with a collagen membrane, definitely.
Yeah. So there's another question. In the end, maybe you can show again the page of the book you are attending. This was a question someone wanted to see again.
You mean the textbook where I wrote the chapter?
Yes. Yes. Okay. There's another question regarding your regarding the Curie technique. Your biggest concern is also about the time you are using or you are spending to harvest the autograft, right?
Yes, absolutely.
So if we would have then, if we would use a cortical plate, would this solve the main concern?
Yes, of course. Because now I know that LifeNet is developing those cortical plates, those allograft cortical plates, which is going to be something very promising, very worth testing, definitely. Because Curie technique is a wonderful technique, but the main hassle is the graft harvest. So, and those plates in the Curie concept, they don't have a biological activity, at least for him. So whether using autogenous plates or something coming from LifeNet, allograft plates, I think is going to be the same. I think it's going to open you new horizons, definitely.
Yeah.
But I don't have experience on that.
Okay, thank you. There's another question from South America. The use of titanium mesh is only to refer to the, or it's a comment to the fact that the bone can be obtained without block grafts. So he is understanding that the reinforced membrane can not be used then there, right?
I didn't get the question properly.
There was the question that the use of titanium mesh is
Okay.
only to refer to the fact that the bone can be obtained without block grafts. It was
Yeah.
a note.
Yeah. Of course. Particulate grafting, of course, is an option, and we know this is an option. Whether with the mesh or with membrane, definitely.
Yes. There are a lot of what bone was used in sinus lift case?
It's the same bone. It's the 70-30 anchor bone, which is similar to the Orograft 70-30 MD. So it's a mixture between DFDBA, 70% of FDBA, the mineralized one, and 30% of DFDBA, the demineralized one, without any xenograft in the sinus case.
Yeah. So here's a disagreement. Sometimes you have disagreements.
Very interesting.
For the use of titanium mesh. So in South America, some of the participants, they are using the titanium mesh and have excellent results with them without using BMPs.
But using collagen membrane on top. Yes.
Yeah. So what do you do with the tooth near to the osseous defect?
Excuse me, Peter.
What do you do with the tooth near to os defect?
The tooth. Okay, if
Yeah.
I treat it chemically or if I clean it, that's the question, I suppose.
Yeah.
I don't do anything. If it's a healthy periodontium, I don't need to do anything. And if it's a deceased periodontium, we have pockets. I need to prepare the case beforehand. So we need to have scaling, root planning, and the surfaces needs to be cleaned from bacteria before the surgery. So at the day of surgery, everything is supposedly needs to be cleaned. So I don't do any DTA. Anyway, I put the membrane always afar, a little away from the root, at least 1.5 to 2 millimeter, to avoid any contamination via the tooth sulcus.
Okay, thank you. Do we have more question? I have to run all the questions. Yeah, maybe you can show this. We are already half an hour, a little bit over the time. Here is the book again for you who asked for. It's the Wiley book, Advanced in Aesthetic Implant Dentistry. Thank you, Rawad. There are congratulations, fantastic cases to both of you, to Dr. Glaser, also to you, Dr. Glaser. There are congratulations for nice presentations and for fantastic cases you showed and shared with us. Here, if you just stop showing your screen, please. There are not more questions coming in. So I would really like to thank you both for the presentation. I would like to thank you to share with us your knowledge. Can you see this?
Before closing,
Sure.
I would like to just say one word concerning the new products that are proposed by LifeNet, because I've been following on the products that you're proposing, So now you have this very interesting product called the Prime. The
Yes.
Prime is very interesting, and possibly it could be interesting also to be used in like in my scenario, to combine it with some bovine bone, because the Prime
Yep.
is very handling friendly, and it is very osteoinductive. It has collagen. It has a lot of properties that are needed to have a nice bone formation, and probably coupled with some bovine bone, probably it could be a very nice graft choice. But this is something to investigate in the future.
Okay, thank you for this comment. For all of you listening today, I hope you all enjoyed Dr. Glaser and Dr. Samarani's presentation. I would highly encourage you to dial in next week again. Next week will be week number 3. We will have next week 2 speakers, one from Spain, Dr. Alberto Monge. He will talk about combined surgical modality for the efficient resolution of peri-implantitis. And we have Dr. George Gomenos from Greece, from Athens. He will talk about his experiences in his cases in soft tissue management in the GBR procedures. So if you find time, please dial in. We are very excited to have so many very fantastic speakers, very good clinicians, and sharing all the cases with us. And finally, I would ask you, if you finish the presentation, the participation today, there is a short survey, only 3 questions, so we can improve ourselves. We can fit in other topics, hot topics you might be interested in. And of course, I wish you all, the speakers, all your attendees, a healthy life. Stay safe, stay healthy, and hopefully we see each other again next week. Thank you very much. Good